Yeah, colleagues, I'm Thomas Bieber. I'm working at the University of Bonn, and I was asked during this IEC session to present a few data about the option of targeting the Th2 receptors and the cytokines in the context of the systemic treatment of AD. And you will hear a lot of other things, or have already heard a lot of things during the session, to which I would like briefly to allude to. So this is my conflict of interest. You see, busy time currently. We are working with a lot of companies because we, as you know, we have a lot of new products in the pipeline. So in order to a little bit explain what I'm doing here, is this just shows you in a little bit my personal view of how we could explain at least partly the pathophysiology of this disorder, where we currently assume that there is a kind of initial phase very early, a kind of innate immune response phase, which is then followed by an adaptive immune response phase. And within that adaptive immune response phase, in fact, there is a kind of T2 response which are supposed to be absolutely crucial in driving the inflammation in that particular disorder. So among the T2 cytokines and the receptors which could be targeted by biologics, in fact, we have different kind of candidates. So the first, which is well known, and I would like to not go too much into the details about the results of the clinical trials, is dupilumab. On the other hand, we now have, and all of you have probably enough experience with dupilumab, and here I just would like to summarize some of the most important real-world reports that we currently have seen in the literature. And if you look around the easy improving scores, you more or less see what we have seen in the clinical trials, which has been published in the pivotals and other phase 3 trials. But I think most importantly is to see here that, in fact, the report about the conjunctivitis, which is, as we know, the most important side effects in that particular set of treatment, can be highly variable. As you see here, from 10% up to 60% in some cohorts. This just exemplifies the differences that we see typically between the typical pivotal results and the real world situation. And the side effects of that kind of treatment with dupilumab has been nicely summarized in the last years. And we can roughly see 3 kinds of side effects that we see typically in the skin: the conjunctivitis that everybody knows. Now, a few cases of secretitial ectropion, as shown here on this slide. And also what is currently called the de novo exacerbation of head and neck dermatitis, which is in that series has been reported in 4% of the patients. So another candidate for targeted treatment is IL-13. Why is IL-13 so important? In fact, it's important because we now know that IL-13 is probably the most important driving force in the skin itself. And IL-13 has a number of different kind of biological effects which are represented on that slide. And you can imagine that targeting that particular cytokine or its receptors may be a very interesting approach in treating atopic dermatitis. There are different ways to interact with the IL-13 cytokine and its receptors. We currently have 2 molecules which will be available in the next years. The one is tralokinumab and the other one is lebrikizumab. Both are antibodies directed against the IL-13 cytokines, but interestingly, both molecules have a different kind of mode of action. I don't want to go too much into the details here, but the 2 molecules, in fact, are different in a way that they either are blocking the binding of the cytokine itself to the receptor, or it's allowing, like lebrikizumab, the binding, but it in fact is interfering with the association of the 2 subunits of the receptor, and by this blocking, in fact, the biological activity. So in terms of results for IL-13 blockade here, the results of the phase trials, With tralokinumab, you see here the extra 1 and 2 studies. So the typical pivotals without topical steroids. You see here that based on the IGA-01, for example, you have a nice and significant difference between the placebo and the typical 300 milligram dose every other week in these patients. The other product, which is currently in the pipeline, is lebrikizumab, which seems to be a little bit better, at least according to the EASI-90 score, which, as you know, is equivalent to IGA-01. Here we have something which is more similar to what we know from dupilumab. Now, another target which is interesting is IL-31, because IL-31, in fact, is also a T2 cytokines, but it in fact is acting directly on the sensing neurons, and by this is potentially interesting because it could block the itching sensation. And there have been some first trials looking at the nemolizumab activity, which is blocking IL-31. And interestingly, you know, the itching sensation, as expected, was nicely improved, and very, very interesting results have generated here. Unfortunately, if you look at the clinical evaluation of criteria like BSA, the EASI score, SCORAD, and so on, in fact, you will see that the improvement in terms of the other scores beside pruritus is quite limited. And this has been, in fact, again, confirmed in the phase 2b study, where interestingly, also there is no real dose dependency on that, of that effect. So the interesting point is here, in that context, that we are always struggling, and there are two dogma, you know, about the pruritus and inflammation story. The dogma one, I would say here, is that the pruritus is at the beginning inducing inflammation. And the other one is that inflammation was first inducing pruritus and then scratching. And what we have learned, I think, from these studies with nemolizumab is that probably at least for atopic dermatitis, at least for that disorder, in fact, probably the second dogma is true. So the dogma is that inflammation is probably first and then pruritus. However, this does not mean that that product is not efficient in another probably highly related disorder, which is prurigo nodularis, because in that recent paper here, you can see that indeed nemolizumab has shown very interesting results in controlling the prurigo nodularis in these proof of concept study in patients suffering from that disorder. So I would like to summarize and to show here that beside the JAK kinase inhibitors that will be presented later on in this session, we now have a number of new molecules that will be available in next years. And this will be a very interesting battle, I would say, between the biologics and the JAK kinase inhibitors. And we will have an enlarged family of different molecules available to control this disorder in our patients. Thank you very much for your patience.